I am delighted to introduce our first speaker. This is Trudie Clark, who's lead tissue viability nurse at Velindre Cancer Centre in Cardiff. And Trudie is going to talk to us about malignant wounds. So over to you, Trudie. Thank you.
Good morning, everybody, and thank you for inviting me to speak to you today. And I'm speaking to you live from the office in the Velindre Cancer Centre in South Wales, where I'm the lead tissue viability nurse. I've been a tissue viability nurse for many, many years now, over 30 years. But I have to say that I've been challenged in this role more than anything when I've been working here in the cancer centre. I really do see some horrific wounds. Now, I know Jeannie will be talking to you about this later when she's talking about pressure ulcers, but I just wanted to raise awareness of this with you. And this is a document called Skin Changes at Life's End. It's an old document now. It's been around quite a long time. It started being developed in 2008. And at this time, the great and good in wound care, mainly based over in Canada and the USA, got together to discuss skin changes at life's end. And Jeannie will refer to this in relation to pressure ulcers, but I just want to refer to it in relation to malignant wounds with you. It might be that some of you know this document well. We've had lots of documents since. This was the original one, and I think the content of this one still applies today. So let's have a look at the next slide to see what we say about that. So you can see here, we've looked at actually defining skin failure. Because when we're talking about people dying with malignant wounds, we tend to think of people dying of lung failure, heart failure, liver failure. But if you think about it, the skin is the largest organ of the body. And when you're dying, that will fail as well. You can see there the blood supply is not as it should be. As a result of that, we don't have a sufficient oxygen to keep the skin alive. So here we do have problems with skin failure. So when we're looking at people with malignant wounds, I'll say later on, they rarely heal. But this is perhaps why they're not healing, because we've got the aggressive cancer, but the skin itself is always failing. Next slide, please. So what this document looked at, it was a Delphi technique, a consensus process that came up with a list of statements that were sent round. People would amend them, people would add to them, sent round again until the definitive document was agreed upon. And here they talked about risk factors. So I'm not going to go into these in detail, but just for you to be aware that these patients have got perhaps slightly different risk factors than ordinary people. They've got different risk factors here. The one I see a lot with people with head and neck surgery is cachexia, when they're very, very emaciated. Obviously, their immune system is compromised because of the chemotherapy we give them. They can have lots of other problems, fatigue as well, and fatigue is a well-known symptom of cancer, especially during chemotherapy and radiotherapy. I've mentioned other points there on that slide for you. So risk factors for these people, slightly different maybe, or more fine-tuned than the general population. Next slide, please. So in the scale document, they came up with some statements. I'm just going to paraphrase these statements for you now, but think about these as in relation to healing or relation to how a malignant wound would develop or change as it goes through its lifespan. You can see here, this is for dying people, and that can take days, it can take much longer, as you can see, and we do see changes in the skin and also pain, but pain is a wider problem for patients with malignant wounds. And here, sometimes there's nothing we can do. So we give the optimum care we can, with it being nutrition, hydration, medication. Sometimes we might stop chemotherapy for a while until we get on top of wound problems. But sometimes there's nothing we can do about that. And we have to acknowledge that as clinicians, because in the past, if these wounds weren't improving, we'd be thinking, well, what are we doing wrong? But you can see now that, you know, sometimes there's nothing we can do about it. Next slide, please. So I think these things you can see here on these bullet points, these to me should apply to any person, whether they have a malignant wound or not, anyone that we deal with in tissue viability. To me, they are key aspects of care. So it's important that we take these on board. And although they're in this scale document, to me, this is just good care, especially patient-centred care, which I was luckily able to speak about at the recent Lindsay-led Club conference, a very important concept that we need to address and grasp in relation to managing patients with wounds. Next slide, please. So here we talk about assessing the skin. And again, with malignancy in the skin, you might have a malignant wound, but you might also have satellite lesions elsewhere on the skin. So we need to make sure our skin assessment is thorough, top to toe, as it is for any other patient that's got compromised or vulnerable skin. But again, that's nothing new. That's what we should be doing for our patients anyway. But again, we need to refer on. So if we think the patient may heal and they're not, let's alert people, perhaps tissue viability nurses like myself. But also at the end of that bullet point there, if the patient or their significant other are concerned that things aren't going how it should be or things are deteriorating and they want more help, again, we need to refer to the wider team. And I'm very lucky here at Velindre. You'll hear two of my colleagues later on today, but we have an excellent team here, whether it be radiotherapy, pharmacy, nursing, the medics, the palliative care team. We've lots of support within this environment. I do appreciate sometimes when you're working perhaps in the community, you might not have this level of support. But if you do need help, reach out because it is there. It's just access that you need to perhaps realise how you can do that, maybe through the GP. Next slide, please. Here we talk about the Ps. And if someone has got a malignant wound, okay, we need to look at what we can do. The first thing is, like with any wounds, we will try and prevent. And we will try that with chemotherapy and radiotherapy, but sometimes the malignant wounds develop regardless of the treatments we're doing. Some of them do heal, not many, but some do. And I do have a positive case study to share with you later. For a lot of people, what we're doing here is maintaining, we're managing their symptoms, we're managing the odour, the exudate, we're keeping people infection-free. So here what we're doing with the malignancy is preservation. And quite often patients will say to me, will this wound heal? And I'm always honest with them. And I say, in my experience, I don't think it's going to heal. But what I can do is A, B, C, and D. So then I try and find something positive. I can help with the exudate management. I can help with the smell. So although healing might not be the outcome, I try and be as positive as I can in relation to my management of people with malignant wounds. Gina will talk about this later on, but again, when we come to the end of life, we alter our wound management. But Gina, I know, is going to talk about this later. Preference is really important, and I find people with malignant wounds sometimes want to try things that are off the scale that we wouldn't normally use. They sometimes want to try different types of things. It wouldn't be what I would say is routine wound management. But we discuss this, we discuss why, and we make sure that the patient is at the centre and their desires and their preferences are the priority. Because at the end of the day, it's not our wound, it's theirs. So patient preference is exceptionally important to us here. We also have to make sure that we've done that final P, haven't we? Because if people are not aware that their skin is failing, they think things can be cured. And in some situations they can, but not always. So we have to be quite honest with our patients here and educate them, especially about skin failure. Next slide, please. So let's move from skin failure now on to malignant wounds. The malignant wounds I see here might be different types of wound. So they could be a primary cancer of the skin. Quite often we're talking of malignant melanoma. It can be a metastasis, so you could have a primary in the lung that metastasizes elsewhere on the body, on the skin. It can be erosion from a deeper cancer, and I'm currently seeing a young lady who's got cancer of the eye, and she has now got an erosion from the orbit and a malignant wound there. Now, margulins also used to be the term used for malignant wounds that develop in scar tissue, which Margulin identified. But now margulins ulceration is the term used for all malignant wounds. It's an overarching term. So if someone's talking about margulins ulcer, they're talking about here a wound with a cancerous origin. But bear in mind, I might have people with different wound types at the end of life or while they've got cancer. So I might have people with malignant wounds, but also people might have venous leg ulcers, they might have skin tears, they might have arterial ulcers. I know Jean is going to talk about pressure ulcers, I won't cover that here. So the way we diagnose malignancy is biopsy. And quite often we have people referred to us too late, and they've been treated for, say, a venous leg ulcer that isn't showing improvement, that isn't healing following the National Wound Care Strategy input. It's just not going anywhere. If anything, it's getting worse. And here then we have to think why. If I've got the right diagnosis, if I follow the right treatment options, I should be seeing signs of healing. But if I'm not, something's probably wrong. And what we say is if it looks strange and it sounds strange, it probably is strange. So here we biopsy. And then what we will do is we will biopsy from the site where we think the carcinoma is active. But if that comes back negative and we still feel there's something strange about this wound, we will rebiopsy. We will divide the wound into quadrants and do 4 biopsies. So we don't just take the result of the first biopsy as a definitive result. We might rebiopsy if we're still concerned we've got carcinoma in situ. But we'll also be doing lots of other investigations. We will be looking at MRIs, we'll be looking at X-rays, we might be looking at ultrasound. So it's not just biopsy, we look at the whole picture to see if we can identify if there's cancer in that person's body anywhere as well as the wound site. Those 2 bottom bullet points, I think, are the ones that I find affect me a lot here in Velindre. If you've normally got cancer, you don't see it. But patients with malignant wounds, they see the cancer. They see themselves rotting. They see themselves deteriorating. And they have to see this quite often on a daily basis unless they're able to not visually see it if they don't wish to. So I think the psychological impact this must have on individuals must be enormous. And we're lucky here at Velindre, we have psychologists for staff and for patients to help them overcome these very difficult situations they find themselves in. And there's a quote there from Gary Sibbald, who was one of the original people involved in the scale document. Next slide, please. I've said they rarely heal. They do rarely heal. It's not normally a possibility for people. And I've said that what we do is manage the exudate, odour, pain, prevent infection where we can. And I try to reduce the impact of the wound on the individual's life. So I try where I can to get dressing changes that aren't daily or twice daily. I'll try and get it longer so that they can have days when they're wound free to a degree and they can get on with their lives. Because the other thing is when you have cancer, you have lots and lots of hospital appointments. You might be seeing palliative care, your consultants, radiotherapy, chemotherapy, me. There's lots and lots of people seeing you. You might still be seeing your original surgeons if you were operated on for your original cancer. So your life is full of cancer. So it's nice to be able to give people a gap when they don't have to worry about the malignant wounds. Sometimes in the acute phase, that's not always possible because they are very, very wet, very odorous. But that's what we aim to do, to reduce this impact on the individual's life, to give them some respite from dealing with this awful wound situation. We also have to tell people that, you know, this might not be it, there might be more to come. So we have to prepare people for that so that it's not such a shock when things do come. So we have to prepare people that that might be an option for them. And these 2 quotes here from Alexander from Australia. And then intense, distressing, unforgettable. That was how patients and their carers felt about having to look after someone or be with someone who had a malignant wound. And then the bottom one is how the nursing staff felt about managing people with malignant wounds. And you don't forget at all. And it can be very, very emotive and very draining and very hard, especially if we go back to that first bullet point, the fact that they won't heal. Next slide, please. Sebastian Props, a person who is very involved in humour, he did a nice piece of work, as you can see, a qualitative piece, asking 9 women on what were their experiences of having a fungating wound. And he's called it malignant fungating wound. And there is debate in the literature about this. Alexander would say that fungating is the appearance, whereas the cause is malignancy. So some say malignant, which I do, but some say malignant fungating, but that's just a debate in the literature. And again, look at those things that they felt they found. And it's what we've already discussed there, really. Bleeding we'll talk about later on. Itching we'll talk about later on as well. But the fact that they can't control what's happening to the body and what they're seeing before their very eyes. And this lady I'm seeing later on today with the malignant wound of the eye, this is in 10 weeks. So she went from being able to see to her now being completely blind and a malignancy on her eye, 10 weeks. We've mentioned having to look at cancerous wounds and how that made me feel, but look at those there, perhaps even more heartfelt thing we heard from Alexander, revulsion. How am I to be revulsed at your own body? Again, the effects on your mental health. Some people feel, why me? Why has it happened to me? What have I done wrong in the past that this has happened to me now? And the frustration of being out of control with the situation that they find themselves in. Next slide, please. I put this in, I realise you can't see it in detail, but the link is there and you are able to get my presentation afterwards without the photograph, so you can have a look at this. There are different assessment tools about. This one I found was the perhaps most recent one, and it talks about the impact of exudate odour pain on someone with a malignant wound. So it is out there if you decide that you want to have a look at these symptom assessments. There's tools out there to help you, but this was just an example to show you. Next slide, please. So we use additional strategies, and we will use these things, and we're lucky we've got a great complementary therapies department here. We use distraction, we use guided imagery, we use music, we use relaxation. You can see with this young boy here, he's using the visual headsets, and we have those here for patients. So while they're having chemotherapy or having wound management, they can put these on and they're on a beach, they're in a pleasant place, so they haven't got to manage these things. So always think about your additional strategies. Next slide, please. So my final slide now, the challenges for me is I'm no good at knowing how the disease is going to progress, but my palliative care colleagues, my ward colleagues are very helpful in saying, I think we're coming now to the end, or we need to manage the situation. But sometimes people do pick up and they're with you for a much longer period of time, or the chemo and the radio or the biologic therapy that my colleague Diana will talk to you about. They really help people, and people's lifespan now is much longer. So that's a good situation to be in. It's very easy to focus on the cancer and forget the person, but we always have to make sure we've got that patient-centred care and the person is at the front. The next couple of bullet points, I think, are things that you feel when you just can't do anything to help. You just cannot meet the patient's expectations, but we have to discuss that between ourselves so that they're aware of why we can't and their expectations are realistic. Client denial doesn't happen where I work because everybody knows, the patient knows what's wrong with them before anybody else. So they're never in denial, as in they don't know what's happening, but they just might have difficulties coping with that. And again, we use psychology support. I have to be very, very aware of the language I use, because that groin modesty looked quite nice because it's quite clean, there was not much slough, but it's not nice, is it? It's cancer, it's malignancy. So we have to be very careful about the language we use. And also self-management. We have a lot of patients who will manage themselves, and I'm not too keen on that because of the issues I mentioned earlier on. So self-management might be a good thing for the general population, but we really have to explore that in our patients, because quite often it's not a realistic option. But at the end of the day, it's patient-centred care, so we will work with them for their options. So if I could have my final slide with my references on. There are 3 of these for you to see, but you'll see them, then you'll see the next 2 slides. We'll put them through now for you because you'll see these when you get the presentation. So next reference slide, and the next reference slide. And there we are. Thank you for your attention.
Thank you, Trudie. That was fantastic. And we've got some questions here, but I think from my experience as well, whether when I was a community nurse, but also, as a tissue viability nurse in the community, you're right. Sometimes you feel quite isolated, and some of these wounds are horrific, horrendous for patients having to live with them. But for those generalist nurses who maybe don't have exposure to these wound types that often, it can be quite overwhelming, can't it? And this is, I think, the importance of having access to specialists in this field to support them, but that's not always available. But people need to seek that advice, don't they, and that support, because people do feel quite isolated in the community. And that's your experience.
Yes, I agree, Sarah. And the problems that we have sometimes with our patients is our patients are walking wounded. Their legs are fine, their arms are fine, they can mobilise. So they don't get district nurse support, they get practice nurse support. And I don't know if there are any practice nurses on here, but I find that practice nurses get even less input or support on malignant wounds than perhaps the district nurses do. So I think we have to bear that in mind. So what I try and do is, if we are working with district nurses or practice nurses, they do have my email address, and we will do joint assessments together, because I'm aware that I'm in a very privileged position of having 5 or 6 years experience of malignant wounds, but that is a rare situation for most people. But there are tissue viability nurses across the UK, and if you're as a district nurse or a practice nurse and you're struggling, get the TVNs in, because they will have that extra level of experience and support.
Someone Carl asked whether larvae therapy can be used to aid slough removal on any of these wound types. Have you had that experience before?
Yeah, thanks for bringing that up, Carl. Thank you very much indeed. Because normally when you think about larvae, you think if people don't like larvae, it's not a pleasant experience. They've got problems with the body image to start with, but what was larvae going to do to their body image? But we have had a couple of experiences, and the gentleman you saw with the cancer of the penis, we use larvae on him, because at the end of the day, if you can get rid of that non-viable tissue in 72 hours, that will take you a couple of weeks if you're using autolytic debridement, that smell will go as well. So yes, we have used them. We don't use them routinely, but we have. We've also recently used them on a young lady who had a malignant breast wound. I had a fungating wound coming from her breastbone. And she approached us and said, could we use biotherapy with her, because she was so conscious of the smell, and the deodorizing dressings we were using weren't getting there, and she thought she might work. So we do use them. We don't use them often, but yes, certainly when we need to use them, we can. And the other thing I would add to that as well is, we haven't done it yet, but negative pressure wound therapy is contraindicated in malignancy because it can increase the speed of the cancer cells. And Jeannie might refer to this, I'm not sure. But at the end of life, if we can use negative pressure wound therapy for the last few days and not have to do wound dressing changes, not have to humbug the individual, we will have that conversation about using that, even though it's not routinely used in that patient population, because we need to make sure that life's end is dignified and comfortable. So yes, thank you, Carla, for bringing that up, because we do use them. We've used them very successfully.
Interesting, thank you. Matthew asks about your viewpoint regarding using enzymatic gels for autolytic debridement, or is it better to allow the fungating wound to dry out with a thick eschar?
It depends. There's 2 situations there. I'm with debridement. I'm quite happy with every method of debridement, whether it be enzymatic, autolytic, mechanical. I'm quite happy. I tend to step back from mechanical and sharp because we have a propensity for bleeding wounds. So I take great care if I'm using sharp debridement, great care. The lady I told you at the moment that's got the mass on the orbit is dry. She's undergoing radiotherapy at the moment, and I don't know what's underneath there, none of us do. So we're going to shrink it with the radiotherapy, hopefully. You'll hear about that from an excellent colleague later on, Jason. And so at this moment in time, I'm going to leave it dry, because until we shrink it and we rescan to see what's under there, we're not going to actively debride. So sometimes we don't debride, but when you saw that it's a situation where we've got cancer of the penis and we've got lots of wet, sloughy tissue, and we know what's underneath, yes, we will debride. And I've no grey preference to which method of debridement. I just choose the one that's appropriate for the patient, but I have no problem with enzymatic gels as a debriding agent. But as I say, sometimes we do keep them dry. We don't have a hard and fast rule. We have to see what's going on underneath what we're seeing on the surface before we make that debridement decision, because sometimes it's not appropriate at that point in time.
Petra asks about how painful these wounds are. What's your experience? Are there some wounds that are more likely to be painful than others, or? Sometimes there's wound-related symptoms like the infection you talked about that can exacerbate pain, can't it?
With pain, what I'd say with pain is I think there's an anticipatory pain, because dressing changes, we know, are the most painful time for people with wounds. So there's always the anticipation of the dressing change. I do get really, really annoyed with people using what I would call suboptimal dressing management. So if we've got a patient that's got a chest wall wound, they need a chest wall dressing size. They do not need patches. Where you've got areas that are going to leak, they need dressings of the correct size. So that's a bugbear, because we find we have leaking and we have to change them more often because we're not using the correct size dressings in the first place. So that's a big problem. So the pain's anticipatory because the dressing changes are normally painful. We will use the alternative therapies, as I've said. There is pain at dressing change. We know we've got nociceptive pain, we've got neuropathic pain. Nociceptive pain, if I did that, it would hurt, it would go away. And it responds to the World Health Organization ladder, but it starts with your paracetamol, your non-steroidals, and goes up to your morphine. If the wound's been open for quite a period of time, and some of these have been, the pain could be neuropathic because you've got damage to the nervous system. And here I could give you as much morphine as we had in the hospital, and that's quite a bit, and it wouldn't touch your neuropathic pain. Here you need pregabalin, gabapentin, and amitriptyline. So first of all, in our assessment, we need to know what type of pain we've got. We could well have both, and then we need to treat the pain accordingly. But here I defer to our palliative care team. I have to say the palliative care team in Velindre are nothing but a magnificent example of nurse specialists to me. They have very difficult conversations and they take people through very painful situations. So quite often there's a pain element involved that's not just wound. The pain is also about what else is going on with the cancer. So yes, they can be very painful, but it's not just are they painful or not. It's a bigger picture than that when we talk about pain in wounds. But yes, they can be very painful. And it's like we're aware, aren't we? You think all these big nasty ones are going to be more painful, but sometimes the very small ones can be as painful, if not worse, than the very large ones that are full of non-viable tissue where you haven't got a blood supply at the surface.
Thanks, Trudie. That's fantastic.